So welcome back, guys. Today in this lecture I'll be talking about the bilateral facial palsy. So over the many years I've seen a lot of people, students, young residents have difficulty in talking about bilateral facial palsy. So if at all next time a patient, as you can see on the screen right now, a patient somewhat looking like this, with both eyes. The patient is not able to close both of his eyes, and when the patient is asked to say E, that is to clench his teeth and say E, the patient cannot do it completely on both sides because of the facial weakness. And also you can see there's loss of nasolabial fold on either side, and the patient is not even able to completely show frowning on the forehead. So this is a case of complete, not I can say complete, but the bilateral facial paralysis. And depending upon the House-Brackman grading system, which I'll cover up in the next lecture, this seems to be the category of I think grade 5 of facial palsy, because grade 6 is complete lack of movements in because of complete facial paralysis. So this either is grade 4 or grade 5, more towards grade 5. So in this video today, I want to make it sure that after you watch this video, you are very much clear of how you should treat and manage a patient of a bilateral facial palsy, and what are the differential diagnoses, what investigations are supposed to be carried out. And similarly, as you can see over here in this photograph, this patient was asked to close his eyes, and you can see a typical Bell's phenomena, the upward rolling of the eyeballs, and there's almost complete absence of frowning. When the patient is asked to frown, there will be complete or near absence of the frowning, and you can see there's loss of nasolabial fold, very minimal evidence of nasolabial fold over here. And the right eye is almost approximating, but the left eye has a huge gap in between. So this also seems to be a grading of House-Brackman of around grade 4, I guess, because up to grade 3, that is a grade 1, 2 and 3, the patient can definitely close his eyes under huge pressure. Even on max pressure, the patient can close the eyes. The eyes can close, the eyelids approximate. But beyond grade 4, 5 and 6, the patient is not able to close the eyes completely, even with maximum pressure or power. So this is how you know the House-Brackman grading, the House-Brackman grading. So I will talk about the differential diagnosis of the. So if a patient happens to come to your OPD, you need to know what investigations should be carried out in cases of bilateral facial palsy, and what is the protocol of management. So as you can see on the screen right now, there is a list of all the differential diagnoses which you have to keep in mind when a patient comes to your OPD or a surgical theater or whatever or outpatient department you are in. The patient will have bilateral facial paralysis, and you have to immediately think of these differential diagnoses, which are not very much, few of them, and then you have to carry out specific investigations depending upon the patient's history exactly. So the most common, I will narrow down the differential diagnosis for you guys, is that the most common differential diagnosis you can think of for a patient of bilateral facial palsy in a regular practice. Now, I should say that this condition itself is a very rare situation, because not all the patients are going to have bilateral facial palsy, but those who have, they have a very rare occurrence, so that you should have a clear knowledge. So the first thing which should come to your mind should be these few conditions, which is the HIV infection, the Lyme disease, Guillain-Barré syndrome, sarcoidosis and syphilis. These are few 4 to 5 conditions that are very common in cases of bilateral facial paralysis. Now, we all know that individual unilateral idiopathic Bell's palsy is quite common. The most common is idiopathic. Then comes the viral infection. So it can also occur that on both sides, the idiopathic or viral infection can occur either simultaneously, or the first on the left or right, and vice versa, with a gap of around 1 month or below. So this is going to occur. So the patient may have a simultaneous occurrence of both sides facial palsy, or may have one side first and the other within a span of a month or so. So that is what you have to keep in mind, the duration and the time of onset. So the first thing, the most common, is the Lyme disease, then sarcoidosis, then syphilis, then Guillain-Barré syndrome. So I'll be talking about what investigations you can carry out and what is the protocol of management. So other conditions which we have to keep in mind is the traumatic, so iatrogenic, then traumatic post-accidental brainstem injury, then post-traumatic infectious diseases such as meningitis, then brainstem encephalitis, then human T-cell lymphotrophic virus 1 infection, then we have the HIV infection, the infectious mononucleosis, where we have the patient with the tonsillitis and diffuse membrane over that, post-influenza cases. Now, in case of traumatic iatrogenic, bilateral facial palsy is very almost impossible, because these days ENT surgeons do not operate on both sides, parotid and mastoid, at the same time. So it is very rare to have that as a cause. Skull fractures you can have in case of huge accidental traumas, and then post-traumatic we have the brainstem infection, the meningitis, we can have the inflammation on the facial nerve. Okay, so there may be inflammation or compression in the internal auditory meatus or the canal on both sides in cases of huge traumatic and idiomatous cases. Then we have very rare cases of patients with diabetes having affection with the facial nerve on both sides. Then the neoplastic acute leukemia and porphyria and all that, acoustic neuroma on both sides. So I'm going to talk about sarcoidosis, Lyme disease, syphilis, and the management, the protocol of how you can investigate the patient and how you treat the patient. So the very first thing is going to be the Lyme disease. Now, as you can see, now first of all, what do you mean by Lyme disease? Now, as you can see on the screen here, it's also called as borreliosis. Why? Because it's caused by a bacteria called as Borrelia burgdorferi. Now, mark my word, as you can see, Borrelia burgdorferi is a bacteria. Okay, it's a bacteria which is carried by a tick called as a deer tick, also called as black-legged tick. Okay, you have to keep that in mind. It's a bacterial disease carried by a tick which is called as a black-legged or a deer tick, as you can see on the screen right here. These are the ticks that a patient, if has a history of trekking or hilly area visit, can lunge onto your body, and after a period of more than 48 hours of body contact, the tick may, if infected with Borrelia, will transmit that into your blood, and then you may get infected and have a reaction which is called as the bullseye sign or the target sign, which I can show you right here. It looks somewhat like this. So this is a kind of reaction rash you're gonna have. So you gotta take patients' good history of traveling into hilly areas, tick bite history. You gotta check the patient's full body for a rash like this. It is also called as erythema migrans, and that tick is called as the Ixodes pacificus, or you can say Ixodes scapularis. So this basic point is really important for you treating the patient with bilateral facial palsy over there. So there's one more photograph I want to show you guys, is this one. So this is how the rash spreads in a period of 1 month. Average is around 7 days. It's called as classic erythema migrans, as you can see on the screen right now. So the rash is it occurs at the site of the tick bite. So it may be itchy or painful, but not always, and it's typically called as the bullseye appearance. So this is a figure you need to look out for. Okay, so that is one thing about the Lyme disease. Now, it's a bacterial disease, it's a Lyme tick disease. So the basic mode of infection is bacteria. So we have to start the patient on antibiotics, high level antibiotic. We can start the patient with doxycycline, or may also start the patient with cephalosporins, which are high levels as well. So we need to treat the bacterial infection and get rid of the tick, if at all present on the body. That's basic treatment. And if at all the patient has bilateral facial palsy, because of that, the patient should be started on IV steroids in tapering doses, methylprednisolone, and then on discharge the patient can be given oral steroids as well on tapering doses. This is how you treat the patient for bilateral facial palsy with Lyme disease. So the second thing is, most common thing which comes to your mind is the sarcoidosis. Now, similarly, what is sarcoidosis? Now, sarcoidosis is an autoimmune disease where the body's own defense system attacks your body's organs. Now, the most commonly affected part in the body is the cervical lymph nodes and the lymph nodes all over the body. Okay, so most commonly the other organs which are involved is the lungs, kidneys, bones, joints, brain, skin. We can have skin nodules over there. So if you can see, the patient may have skin nodules like these. So these are the nodules which you can see in cases of sarcoidosis. So you have to check for the patient's skinny areas where the patient feels itchy or has a rash. So we can see nodules like these, and if sent for biopsy or sampling, we can have epithelioid granulomas inside them, which is suggestive of the the autoimmune, the sarcoidosis. So the basic investigations, if you're suspecting a patient with sarcoidosis, is a CT scan mostly or chest X-ray. But to have a better investigation, it's a CT scan chest HRCT. So you can see a lot of opacification on this patient's chest X-ray bilaterally. You can see a lot of opacities, mostly in the hilar region, suggesting that the patient is undergoing hilar lymphadenopathy. So the only thing which can prove apart from the symptoms and the history of the patient to be for sure is the hilar lymph node biopsy done by bronchoscopy endoscopically, and on the investigation biopsy we can see a lot of epithelioid granuloma formation that suggests the patient has got sarcoidosis, and the treatment is solely steroids. The treatment is solely steroids, as this patient is the condition is autoimmune. So we can start the patient on steroids, IV antibiotics to rule out any underlying infection. So the investigation, apart from the chest X-ray and the CT scan, the HRCT, is a very important investigation. That will be the angiotensin converting enzyme levels, serum, as well as CSF levels. So the CSF levels of the ACE and the serum levels of the ACE are important, has to be done. If there is a profound increase in the ACE levels in the patient's serum, or mostly in the CSF, definitely the patient is undergoing changes in sarcoidosis, and hence the patient must be having bilateral facial paralysis as well. So this is how you should progress with the patient with the investigations and start the treatment as soon as possible. The third disease which we should consider, the most common apart from these two, is the syphilis. Now we all know that syphilis is a sexually transmitted disease, and it's a treponemal disease. Okay, so spirochetes, so we have to do a dark ground staining on that patient's samples. The patient may have skin nodules in the groin area and typical the private parts. So we got to get a good examination done. If at all there are skin lesions, we need to get a biopsy done and start the treatment ASAP. So we need to also consider the syphilis as well. Now coming back to the differential diagnosis table that I showed you some time back. So we read about the Lyme's disease, then the sarcoidosis, then the syphilis. We also can see in cases of poliomyelitis, HTLV1 infection and all that, Guillain-Barré syndrome. Now, if the patient has got Guillain-Barré syndrome, it is also called as the ascending neurological disorder, in which the patient's lower limb is affected first. It's a wasting disorder, and slowly it ascends upwards from lower to upwards, and eventually the lungs, the muscles are wasted, and the patient has complete respiratory failure, and then eventually it goes above the shoulder level, and then it may affect your bilateral facial nerves to give you a bilateral facial palsy. The patient needs to be admitted in the ICU and start treatment accordingly, and to be kept under observation. So Guillain-Barré syndrome has a good response, but sometimes it may not have. So the patient should be kept under a close watch of an intensivist and a physician. So this is how you should individually go with all the particular differential diagnosis and start the treatment. So sometimes a patient may have individual unilateral facial paralysis, idiopathic post-viral, that can occur simultaneously on the same side or the opposite side as well. And in that case, purely the treatment becomes steroidal. So if the patient has got diabetes, you have to keep a check on the insulin level, because in cases of diabetes itself, severe diabetes, uncontrolled diabetes mellitus, the patient may land up with bilateral facial paralysis as well. So in that cases, we have to start steroid, but we need to control the sugar level as well. So we need to start the patient on insulin injections as well. So many more infectious diseases are there as a differential diagnosis, but these, whatever I spoke about, they are in common practice in patients with actual bilateral paralysis of facial nerve. So this is what you can do, and this is what you can go further with the investigations. And so the mainstay of treatment still lies to be the steroid and physiotherapy of the muscles. You can give electrode therapy, you can give electronic stimulation to have a faster recovery of patients. Now I would like to show you a photograph. Yeah, this is actually 4 stages of the sarcoidosis. Stage 1 is lymphadenopathy, stage 2 is infiltration, stage 3 is infiltration only, the lymphadenopathy goes away, and stage 4 is the final stage, which you can see the fibrosis occurring in the lungs. So we need to get the treatment started. This is sarcoidosis. This is ocular ophthalmic sarcoidosis. Now it's a systemic disease, occurs in a lot of multi-organ failure as well. Multi-organ system is involved. You can see this is the lung involvement, the hilar lymph nodes, the optic neuritis, erythema nodosum, typical appearance of skin lesions in cases of sarcoidosis, along with lupus pernio. So all these signs and symptoms are suggestive of sarcoidosis, which can lead to a better treatment, as we all know. So this is a rough estimate of how you can actually see. This is a patient of almost near grade 3 facial palsy, bilateral facial palsy, and the patient will have a good improvement. That's the same patient actually after a particular while. So this patient was having grade 5, almost grade 5 House-Brackman classification, and after that the patient showed a lot of improvement. You can see the steroid becomes the mainstay after having investigated the basic differential diagnosis of the patient. So the history taking and the differential diagnosis are of real importance, and the mainstay of treatment is the antibiotics and the steroids in tapering doses, and all the relevant investigations which a patient should undergo. So I hope you like this video. Whatever doubts you have in this video, whatever query you want to ask, or whatever points you think I may have missed out, you can feel free to comment in the section below, and let me know about the view. Whatever experience you have in your career with dealing with whatever experience you have in your own career of bilateral facial palsy, you can also express your views in the comment section below, and whatever doubts you have, I'll be free to respond to them always. So till then, I'll see you next time in the next video. Till then, take care guys. Thank you so much.